What's going on, everybody? Welcome back to another episode of the Core Consult RX podcast. And we got a full house today.
Yeah, using all the mics.
All of them, every one of them. Rashshana back in action. Rashshana, what's up?
Hey, I miss being here.
We miss having you. And of course, we also have our good buddy who doesn't want to talk, but he's going to anyway because he's a team player. Jason, what's up, man?
Nothing much. How's it going?
Good. Thanks for being here. I know this talking in a mic up in front of a bunch of strangers is not your forte, but it's okay. We're going to learn to love it.
But basically,
Give it a whirl.
He's saying you're on rotation with him, so you're going to do it.
I'm being held
There's
here
no
against
choices.
my will.
Yeah,
Tell everyone. Send help.
he's handcuffed to the table right here.
Yeah, my rotation's a nightmare for everyone. It's torturous for everyone involved.
Long hours, no sleep.
It's rough. That is true.
All those trials you have to read.
Right.
All those,
exactly. Rashshana,
all that learning you have to do.
Rashshana survived it. You'll be good. Rashshana, I was thinking about you because I don't know if I told you or not, but we went to Grenada like a week ago.
What?
Yeah, loved Grenada.
Wow.
And got to hang out with some people. There's a couple people from Jamaica there that were talking, and I was like, "Hey, you sound like my friend's accent." I was like, "I know that one."
Well, I'm slightly offended because you didn't go to Jamaica, so...
Listen, we planned the trip a while ago, but long before I met you. Otherwise, I would have changed it, and I would have gone to Jamaica.
Okay.
Jamaica's our next. Actually, Barbados is
I
our
was
next
going to say,
one,
you
but
booked another one. Was it Jamaica?
it was
But no.
Barbados. But thanks for calling us out, Cole. Jamaica one day, though, I promise. But
Telling you, it's worth it.
I believe you.
And Mike's like, I have to book another all-expense-paid resort in Jamaica.
It's rough out here. It's rough out in the suburbs.
Tough for you, Mike.
Dude, I'm going to tell you a funny story real quick about that Rashshana told me. Because we were talking about when she first got to the States and stuff, and she said that she had seen like all like videos of like New York and stuff like that. So in her mind, that's what the States were like. First place she got to visit was Orangeburg, South Carolina.
Nice.
And it was a little different than New York, right, Rashshana?
It's not New York.
It's the New York of the Midlands.
You're like, I left paradise for this. This is a nightmare.
Nice.
So yeah, I thought that was pretty. I was cracking up when she first told me that. It's like, hell, gosh, Orangeburg, that's the place we go through as fast as we can, so we don't have to stop.
That's like 2 minutes on the interstate. That's all I know about Orangeburg.
No offense if you live in Orangeburg.
Oh, yeah. Great place. Good people.
Solid people.
Yeah.
Wonderful people.
Yeah, there you go. Now you're not offended anymore. All right, guys, what are we going to be talking about today? Rashshana,
Oh, go ahead.
Rashshana came up with the great topic that all of us are just very knowledgeable in.
Yeah.
Well, today we're going to talk about pericarditis.
Exactly.
Yes.
So I was like, oh, yeah, I guess we all start doing some review real quick, get up to speed, because that's one we don't deal with very often.
We've done some cardiology stuff.
Yes,
Yeah.
definitely. But this is one we definitely have not done. You said you
No.
didn't even have to check the list. We knew
I
that
knew
one
it
offhand.
off the top of my head.
That's awesome.
Yeah.
So, Rashshana, why did you pick this one? Have you been seeing this kind of stuff on rotation? Or what made you come up with this topic? Is this kind of a random...
So it was one of the interesting cases. We were doing rounds one day, and a patient had pericarditis that was induced by one of the immune checkpoint inhibitors. And everyone's saying that it's becoming more common. And since we're only making more immune checkpoint inhibitors and more monoclonal antibodies, I thought this would be a relevant topic that you'll probably see in more patients.
So you saw it as a side effect.
Yes.
Interesting.
So, give us a little bit of insight right there, because about that class of drug. So the only time... Like the main drug that I'm thinking about with this is something like one of the anthracyclines, like doxorubicin or something like that. I know it can cause every once in a while can cause cardiotoxicity in general, but also pericarditis. But which class did you say that you saw it in?
The drug was pembrolizumab.
What were you working? What kind of patient population were you working with?
It was cardiovascular rotation. So it's CARDS patient. They just come in. The guy was having a lot of chest pain, and on workup they found out that, hey, he's taking this pembrolizumab.
Okay, and so that's what led you to.
Yeah, that's what made me want to pick this topic.
So it's interesting. You like it a lot. So you're gonna blow our minds. Then we don't have to talk.
So interesting. So much stuff.
That's good. I like it. Now I don't have to talk anymore. We're gonna shut my mic off and let Rashshana take it away. But yeah. So where do we want to start with this? You just get some background information. Cole, you got some background information, right, from the wife? She had to educate you a little bit?
Yeah, well, she reminded me a little bit of about some of the medical terminology that I don't deal with as often. But yeah, we can just start with what it is. So acute pericarditis, inflammation of the pericardium, which is that fibrous sac structure around the heart that kind of serves many benefits, but kind kind of reminds you of the pleura around the lungs or even the meninges in the brain. But it's characterized by pericarditic chest pain usually. They may present with like a increased heart rate or some other thing, but a lot of times it's chest pain, and you have to delineate between that and an MI. Also pericardial friction rub, and you're going to see some pretty specific ECG changes. And if you're trying to determine whether somebody just has pericarditis or is having an MI, that's another way, is going to be the ECG, and there are some subtle differences between the two that you will see. But with pericarditis, you may see a new widespread ST elevation or a PR depression, and you may also have new or worsening pericardial effusion.
Yeah, there's a really good kind of Medscape review on pericarditis where they walk through like the ECG findings that can help with some of the differential diagnosis. And so they talk about some of the differences between that and MI. So if you're like super into reading ECGs, which I can't say that any of us are necessarily.
Oh no, definitely not.
Then definitely check that out, because I think it can help. And there's a lot of things obviously that can present as chest pain. Everything from esophagitis to regular angina to MI to this. I mean, there's so many different things it could be. So it's definitely not as simple as, oh, chest pain, done. Mm-hmm. And you mentioned the sternal rub. You said
Pericardial friction rub.
Friction rub. And Jason, you were telling me a little bit about that. You actually found a good video that kind of gave you some sample sounds of what that would actually sound like with the stethoscope on the person, right?
Yeah, he basically summed it up as two pieces of sandpaper kind of rubbing together if you were to listen to the heart sounds while it was occurring. And then I also saw that as far as like chest pain goes, it was something that people felt like they had their pain worsen whenever they were taking deep breaths, and that it was improved when you either sat forward or stood up.
That's interesting. Were you able to hear that, Rashshana, at all in your patient? Did they give you a chance to participate in that part?
As a pharmacist, I try not to examine patients.
Sometimes you got to live a little, you got to hang out with the real doctors and let them listen to put the stethoscope in. They feel like you're a part of the team. She's like, no.
She's like, COVID, no, I'm not getting close.
That's true.
I'll handle the drugs. Thank you.
So, as far as like what could actually cause this to happen, there's several potential causes. I mean, there's idiopathic. There's several different types of infectious conditions. It could be everything from viral, bacterial, or even like a tuberculosis infection. There's different inflammatory or rheumatoid conditions that can cause it, everything from RA to lupus, scleroderma. There's rheumatic fever, metabolic issues that can cause it. Renal failure is a big causation of this. Hypothyroidism can lead to it. And then obviously different cardiovascular disorders. So you could have acute MI that could then eventually lead to pericarditis. You could have aortic dissection. The list goes on and on. Neoplasms, certain medications, like Rashshana was saying, that's how her patient got it. There's a lot of different things that can actually lead to this. And as far as how that differentiates how you handle the patient, the treatment options, there is some slight differences, but the main kind of focus in a lot of these, the most common form, like the idiopathic and whatnot, the viral is very common, is to treat the overall inflammation.
Mm-hmm. And sometimes that involves treating the underlying condition depending on what's causing it, right?
Absolutely.
But using drugs to treat the inflammation. But a little more about the pericardium too, because I mentioned that it's beneficial, but it kind of serves three main functions. It has a mechanical function. So the pericardium promotes cardiac efficiency by limiting acute cardiac dilation. It also maintains ventricular compliance with preservation. So that Starling curve that you probably learned about with your cardiac patho class, it's important in that function. And also distributing hydrostatic forces. Creates a closed chamber with, as far as pressure goes, that aids atrial filling. It also lowers cardiac pressures. It also has a membranous function. So kind of like a pericardium, the pericardium shields the heart, reduces external friction. And also, it has a ligamentous function where it can anatomically fix the heart if there is a issue going on.
And as far as like definition, the diagnosis, the American College of Cardiology has a review that was published on their in their journal back in January of this year, and basically they say that acute pericarditis is based on obviously the overall differential diagnosis, but they say that it's based on the presence of at least two of the following four criteria. So they mention chest pain, so characteristic chest pain, the pericardial friction rub, like Cole was talking about, and then the characteristic ECG changes, and the new or worsening pericardial effusion. So they have to have two of those four to kind of reach that criteria for diagnosis.
Yeah, and pericardial effusion just being fluid or blood buildup around the heart. Yeah.
Isn't there always blood in the heart?
Not around. Well, I guess there would be around too.
Yeah, see, it's fine.
We'll say excess.
Excess blood. You have too much blood.
Mm-hmm.
So it's like, that's like the people that used to treat people back in the 1700s with bleeding. Remember? That was the thing.
Like bloodletting.
They were onto something.
You think so?
R.I.P. George Washington.
The four humors. Yeah.
I'm pretty sure that's what happened to him.
Didn't we talk? It is. Didn't we talk about that on one episode?
Probably.
Yeah. It's interesting.
Yeah. It's very. Should do a whole episode on bloodletting.
Yeah.
End of the episode. Don't do it, by the way. Moral of the story is the evidence doesn't show it helps much.
It's the 2-second episode.
Yeah.
But as far as from a patho standpoint, what causes that inflammation? Infiltration of polymorphonuclear cells, the PNM leukocytes, and pericardial vascularization. That's primarily what functions and causes the acute inflammation.
Some laboratory studies to kind of look at. So, looking at like a regular CBC, and then doing things like looking at your electrolytes, your BUN, creatinine levels, and then some of like your inflammatory markers. So like your erythrocyte sedimentation rates, C-reactive protein levels, and then some of your cardiac biomarkers, maybe your lactate dehydrogenase, the serum glutamic oxaloacidic transaminase. I can never say that word.
Nice.
That was brutal.
Nailed it.
Rashshana, don't laugh at me. It hurts my feelings. She's covering the mic and laughing. We're going to have that on record now, Rashshana. Everyone needs to know that you're bullying me.
I wish I could say that word myself.
Yeah, it's a tough one. But so those are some of the lab values that also can obviously help with the diagnosis.
And then what about as far as where you're treating them? So it doesn't always have to be inpatient. It depends on the risk factors. So if they're very low risk for complications, it can be managed outpatient. But if they have risk factors like a fever, they define it as above 100.4, a subacute onset immunosuppression, trauma, if they're on anticoagulants, or they have failed an NSAID or aspirin treatment already, or there's significant effusion, or if they think there might be cardiac tamponade, then those would be poor prognostic factors. You would definitely want to be treating those inpatient. But if they're treated outpatient, if they don't have high risk, they can be treated outpatient without serious complications, and the usual follow-up on that is about 38 months, which is a fairly long time.
Mm-hmm. So where do you want to go? Anything else before we kind of just discuss some of the treatment options?
Oh yeah, so pericarditis, it can present in you can have four different forms of it. Acute, which lasts about 4 to 6 weeks. It can be incessant, that lasts more than 4 to 6 weeks without remission. So the patient starts experiencing these symptoms without any break. Recurrent, where the patient had a previous episode and 4 to 6 weeks have passed and a new episode starts again. Or the patient can just have chronic pericarditis where it lasts more than 3 months.
Good stuff. And then I'll bring up your patient again, Rashshana. So when in that particular case, because the medication kind of led to him developing that, what are they going to do in that case? Are they going to try to switch his medications around, or, how are they handling that?
So for this patient, they're thinking of switching his medications around because they don't want to keep him on that toxic drug.
Mm-hmm. So that'd be a hard choice to make, especially if it's a medication that's dealing with something, obviously very significant. And
what was he being treated for? Do you know?
I think his pembrolizumab was for his cancer treatment. So there's concern about his pericarditis actually being pericarditis versus some form of metastatic cancer.
Oh, really?
Yeah.
Yeah, and it's significant with patients of malignancy or patients with cancer. It is most common in them And a lot of times, if it's cardiac tamponade, which is kind of a more severe form of pericardial effusion causing excess pressure, where the heart effectively, you have like overall hemodynamic changes because of that, whereas with effusion you don't necessarily, but with tamponade you do. And it's much more urgent, but that frequently is a complication of patients with malignancy and
I'm
cancer.
happy you mentioned that because this patient had a lot of pericardial effusion. They had to do 2 pericardial syntheses on this
Yeah.
patient, not just one, but a couple of days later, just go back in again, poke that needle in, and remove some more fluid.
Right. And with just standard effusion, that's not always the first thing to go to. So his must have been more severe, probably merging on tamponade,
It
I would say.
looked like one of his chambers of his heart. That's how much fluid he
Really?
had.
Jeez,
It's a lot of fluid.
that is a lot of fluid.
Did you get to watch the synthesis?
Unfortunately, no. Again, that's why I'm the pharmacist.
Yeah, I bet it was gross, man.
Rashshana, who did your priest? I need to talk to your priest. They're not letting you see any of the cool stuff. I got a major issue with this person. Unbelievable.
Yeah.
What are they teaching kids today?
I know. They're not showing them the gross stuff.
Yeah, it's unbelievable.
They're just all watching on TV. That's all.
I blame social media.
Yes. Social media is the devil.
As we're on it all the time.
I know, that's-
Whoops. All right. So, treatment wise, especially an outpatient, is pretty straightforward. Luckily, we got,
It's a serious issue,
it is. Yeah.
but there's kind of straightforward treatment options.
Thank you, Cole. I don't want to downplay it.
Yeah.
But in most cases, acute pericarditis can be treated with Nsaids is the primary treatment course. So, the guidelines itself will say doing an NSAID for typically 2 to 4 weeks, and then after the symptoms resolve, and then from there, and you could. That's the other thing is which NSAID to use. I mean, I've seen some data with ibuprofen. You see some with aspirin.
Yeah.
What did you guys end up using, Rashshana?
So for this patient, it was mostly it's interesting. It's an interesting case because we couldn't do the usual NSAIDs because the patient had cardiac problems. So we had to go all the way down to the corticosteroids.
Okay.
Yeah.
And he failed colchicine, which would be the second one.
Right.
But if he were a more normal patient, then we would definitely go with the ibuprofen route first.
What were the cardiac complications that kept them from doing NSAIDs? Do you remember offhand?
I don't remember offhand, but I think it has something to do with HFrEF.
Okay. Yeah, that's a tough one.
Yeah.
I would think too. Like, I guess
It's interesting because it's a risk benefit situation there, and I don't know. I feel like it's more of a long term use of NSAIDs that increase risk for heart attack and stroke. But I guess we don't know what was going on.
so. The heart attack, the MY one, that they did do that meta analysis that showed that it can be increased even like within the first week or two of starting NSAIDs. But I do feel like that's going to be the ones that lean more COX-2 selective. So like the diclofenac, I know is a big culprit of that.
Yeah.
But like things like the big meta-analysis that look at things like naproxen seem to be fairly safe from a cardiovascular standpoint. So
Which it doesn't really pop up. I mean, it is an option, but it doesn't
Yeah.
pop up in like the first couple that you choose.
no,
with this.
it doesn't. It's usually ibuprofen or anything. Indomethacin is another one that pops
Yeah,
up.
which it has more side effects and a poor side effect profile, I guess, than ibuprofen. But
Yeah.
it does pop up as an option.
The guidelines even recommend ketorolac and say limited to about 5 days.
Yes, definitely can't use ketorolac for more than 5
Oh,
days.
yeah.
But yeah,
Ketorolac. That stuff's crazy.
it's crazy.
You almost
man.
never see it other than the IM shot just to get them started.
They dispensed it out of the hospital a lot. At least I see it out
Really?
of the hospital a lot. Mm-hmm.
So as far as NSAIDs, obviously that's the kind of like the main treatment option, but then there's also an add-on to that. And Rashshana, you mentioned it briefly. What are we given?
So you have to add on colchicine for the patients for about 3 months if they're having an initial episode of pericarditis. And if they're having a recurrent episode, then it's a 6-month duration of the colchicine, which is dosed based on their body weight.
So it's interesting because there was actually a study done back in 2013 called ICAP. And what they did is they were looking at patients who were being treated with their first episode of acute pericarditis, and they all were treated with NSAID. So it was their normal first line options, and then some patients were getting colchicine, some were getting placebo. And the dosing for the colchicine was a little different because they used the 0.5 milligrams and 1 milligram, but that's because I guess the European dosing I think is the 0.5. We have 0.6 because Who knows why?
America.
That's such a, yeah,
We want to be better.
because
We need more.
America.
America.
That's a good point. Jason brought a very good point. That's
Excellent job, Jason.
We're like, you know what? No, give us an extra 0.1 milligram. We're not doing this 0.5 stuff.
That's my
It's like the,
contribution to this discussion.
But it's the same as aspirin, 81 versus 75. You know,
Yeah. Why?
we just have to be better.
I have to, and it's cocky. It's very cocky. Yeah, that is weird. There's got to be a better reason than that. There has to be. And now I feel like I should Google it and find out what that is.
No,
But no,
we should leave it where it is.
That's a good point. But since we do have so many international listeners, they're probably like, "Yeah, you guys do dumb stuff like that."
You guys are dumb.
We
Imperial system.
81 milligrams is definitely an odd one to land on with aspirin too. That is weird.
75
But yeah,
makes so much more.
so much more sense.
0.6 is an odd one to land on with colchicine.
Super weird.
Yeah.
That's why I think that one was definitely us showing off.
Yeah.
I feel like that's a very high likelihood.
Well, the colchicine, it probably, I guess aspirin would have come first, but if colchicine had, they'd be like, let's do 0.1 milligram more. Then aspirin comes, they're like, no, we're going 6 milligrams more.
Yes.
Knock it out of the park.
Knock it out of the park. There's something with the 6 that I feel like the Illuminati is at work. You know what that is, Rashshana?
You seen the dollar bill, right?
That's what really runs the country, apparently. At
That's
least
what I've heard.
according to some things I've watched on YouTube.
Yes.
My Wikipedia research. Sometimes you got to go deep in that conspiracy
It's that-
theory.
it's that
We'll talk.
5G,
Don't even
man.
start on flat Earth.
It's that 5G.
The 5G. Oh, jeez. We should start a new podcast where we just talk about that.
Illuminati.
Something.
So we'd probably be killed.
Maybe that
You
would.
know,
Yeah,
somebody come get us.
that's
Get
true.
too close.
Get too close, we catch on so quickly to them. Be right on their tail. But okay. So, anyways, the ICAP trial. Going back to that, the ICAP trial, and what they were basically including was patients that were 18 and older. It was the first episode, like I said. It was acute pericarditis, and it was deemed as either idiopathic, viral, post-cardiac injury, or connective tissue disease related. And I guess I don't know if this would be considered post-cardiac injury, because I guess technically the medicine was causing cardiac injury. So I don't know if this guy would be classified as that, but probably.
Yeah, I would put him there.
And then the same thing like the guidelines talk about, where they have they included patients who had 2 or more of the following. They said chest pain that is sharp and periodic in nature, improved by sitting up or leaning forward, just like my man Jason said. Jason's on it. And then pericardial friction rub or widespread ST segment elevation or PR depression on EKG finding, and new or worsening pericardial effusion. So any of the 2 or more of those, they met the criteria. Now, they also took out excluded patients who that was from tuberculosis, or if it was neoplastic in nature, patients that had like severe liver disease because of the colchicine. I guess, we're not trying to make that worse. And several other types of things like life expectancy less than 18 months, et cetera, et cetera. Look up the trial if you're super interested.
It is important, though, to mention all those different causes, idiopathic, viral, connective tissue, because what we're really doing is treating the symptoms, which is just the inflammation, to prevent an ongoing issue that gets worse. So with the Nsaids, they're kind of high doses, relatively speaking, not like higher than you've ever seen, but they say a full dose Nsaid should be used. So if it's aspirin, it's 2 to 4 grams a day. If it's ibuprofen, it's 1,200 to 1,800 milligrams a day. Indomethacin is 75 to 150 for 1 to 2 weeks. And that's or maintained until the C-reactive protein is normalized, and then you have to taper over 1 to 2 weeks because it can recur. It's not necessarily nipped in the bud after that.
And also the patients in this study were given a PPI as well, I guess, to protect from gastric ulcers and all that good stuff. So what they were looking at, the primary outcome was looking for incessant or recurrent pericarditis, because that was a big question. Is like we took care of the first episode, the patient got better. What's the likelihood of them having a recurrence? And what they found was that when you add colchicine to it, and what they did is they did colchicine, they did 1 milligram. So that would be the equivalent of like our 1.2 milligrams with some pieces chipped off very carefully so that it's accurate. And then they gave that daily for 3 months. And then if the patient's weight was less than 70 kilograms, or if they are having issues like symptoms, side effects, whatever, they would drop it to the 0.5, or in our case 0.6 milligrams daily, and that was compared against placebo. So at the end of the study, what they ended up finding from the primary composite, and this was insistent defined as, when they say insistent, they define that as persistent or a symptom-free interval of less than 6 weeks. And they found that 37.5% of patients met that, or were kept from having a recurrence, and then 16.7 in the other group. So the number needed to treat was significant. The number needed to treat was only 5. So it was such a low number needed to treat. In fact, it was also better when they looked at all the secondary outcomes. So persistent symptoms at 72 hours, number needed to treat was only 5.
Nice.
Remission at 1 week, number needed to treat was 4.
Oof.
I've never seen number needed to treat this low.
Oh, how many patients were in that trial?
4. I'm just kidding. I'm just teasing.
6.
It was 120 in each arm.
Gotcha.
So 280 total, and then some of them, well, I guess, were
Dropped
lost.
off, maybe.
Yeah. So let's see what else. Cardiac tamponade was not significant, so that's one that wasn't different. But basically everything that revolved around the pericarditis itself, or even like pericarditis related hospitalization, was significant with number needed to treat of 11. So all of those things basically were better. So that basically that's kind of standard of care now, as long as the person doesn't have any contraindications or anything.
Yeah.
If you want the person not to have a recurrence, add that colchicine.
Yeah, so it's primarily from that trial.
And what was also weird too is the adverse effects. So I know when I heard 2 tablets of colchicine basically every single day, which isn't out of control with someone taking like gout with like tophi or something, but the adverse effects when you compare the two. So any adverse effect showed up as 10% in the colchicine and then 11.7% in the placebo group. So no serious side effects were reported in either group.
It's good. Not even diarrhea.
So that's the other thing. They just started right off with 2 tablets. I would say that's hopefully you're starting that and at least giving them some warning that look, stand by, be somewhere where you don't have to be out in public, because colchicine can cause a little situation.
The dose was split though, wasn't it? It wasn't.
I have to look back. I think
thought
it was
saw
probably split.
Twice a day.
Yeah, it probably was.
Okay.
Probably helpful then.
Yeah. But
You get a half diarrhea twice a day instead of a whole diarrhea
In the evening.
once a day.
right. I just give mine with Victoza, and I just call it the constipation and just clear it right up. Don't do that either.
So you mentioned that your patient, who it was from a side effect of a drug, got steroids. So one of the marks against steroids is that they can delay myocardial infarction healing. So you can have pericarditis after having an MI. So we talked about trying to separate the two, but you can have an MI first and then have pericarditis following. So that obviously would not apply to your patient, but that might be a reason not to use steroids and go for one of the other more first-line options. Though aspirin is recommended if it is pericarditis post-MI. Aspirin is the NSAID that's recommended.
The only one.
Yeah.
And, I guess that makes sense because it's mostly working towards COX-1. And I guess we could throw this in there just for, so I think we've talked about this with osteoarthritis, but when you think about the reason that whole talk between, whether we want non-selective NSAIDs or like COX-2 selective, like the celecoxib, or aspirin, why we give aspirin is like the NSAID of choice for like cardiovascular, prevention when it comes to like secondary issues. If you think about like the COX pathways, so you have arachidonic acid and you have COX-1 and COX-2 enzymes coming from there. And some of the byproducts of that, on the COX-1 side, you're getting things like certain eicosanoids like thromboxane and some of your vasoconstrictor type eicosanoids. And then you have on the other side, the COX-2 side, you're getting more of your dilatory, so like prostacyclin and some of those. So when you are you're blocking the more on the COX-1 side, like with aspirin, you get unopposed COX-2 activity, which then means you're getting more prostacyclin production, more vasodilation, and so it allows for less chance of cardiovascular issues. Now, the flip side of that, just like we were talking about with diclofenac, that's going to lean more on the COX-2 side. So you're shutting down more prostacyclin activity than you would be thromboxane. So you start getting a higher concentration of thromboxane and other, endothelin, and there's other, vasoconstrictors. You get a higher concentration of those. That's going to lead to a higher likelihood of a cardiovascular event because you're getting vasoconstriction over time, all that good stuff.
Right.
So just in case you were ever wondering about that, there you go. Throw that 2 cents in there. That was free, Rashshana. How about that?
Clinical pearl.
That's what that is.
Yeah, every once in a while we throw one in there. Not a lot, but
Sometimes people learn something from this. Just every once in a while.
most of the time they just fast forward through our nonsense and get to the end.
But for the steroids, so in general, I should say steroids shouldn't be used for initial treatment. So patients who maybe it's indicated because of an underlying disease, or they didn't have a response to Nsaids or colchicine, or they're contraindicated. So for your guy, Nsaids contraindicated, colchicine not effective. So we're going with the steroids.
Yeah, and the steroids are actually associated with more prolonged course and the higher recurrence of the disease. That's why they want colchicine from the ICAP trial that Dr. Corvino talked about, and the COPE trial that also showed the same reduced recurrence and hospitalization for patients that use colchicine.
Nice. And also, as far as treating the underlying condition, so for your guy, it was a medication issue. So we're swapping the medication. With viral stuff, you kind of just have to wait it out. With an MI, you treat the underlying condition. But that's what this is. It's kind of a secondary issue that has symptom management that's needed.
Yep. There's also other therapies that they're kind of looking at and have considered. So, like if it's beneficial in patients that are, this is straight from the American College of Cardiology summary. They say there's been certain medications that have been shown to be beneficial in patients with refractory corticosteroid dependent disease. So some options that you could consider would be things like azathioprine or methotrexate, some of the DMARDs that we would think about for like rheumatoid conditions and inflammatory conditions. They've also used like intravenous immunoglobulins, and then surgical parodectomy is considered as a last resort kind of thing. So you can get real fancy with it, but I would say defer to cardiology.
Yeah, they usually save the surgeries for last.
Yeah, I know when I'm doing surgery, I always save it for last.
They say surgeons, though, they like to have it first.
Yeah, well,
I don't know, though.
I'll ask them. Rashshana, ask them for me, okay?
I will do that tomorrow.
Okay, perfect. Thank you. All right, guys. What anything else? What did we miss, Rashshana? Anything?
I didn't say you miss it, but you can use IL-1 blockers like anakinra in patients that have acute pericarditis also. There's only one trial that is like mostly just case studies that they've used, but it's being proposed now, so it's an option.
Nice.
I should also say, because we covered everything else, we didn't miss anything except for this one thing. I mentioned the cancer was the most common cause of pericardial effusion with tamponade in developed countries, but tuberculosis in endemic areas can also cause tamponade and should be considered if you're in an area where tuberculosis has high infectious rates.
Yep. Remember when we did a podcast on tuberculosis and then literally the guidelines changed 5 minutes later?
We did the podcast, though.
We did.
And you know what that means?
We got to do another one.
We got to do another one.
Thank you. I'm so glad the guidelines changed. It gives us one more topic we can talk about. Rashshana, sometimes we run out of things to say. And
I don't believe it.
No, well.
Mike always has something to say.
Which is usually not important. So, Rashshana, what's next for you?
Next, I go do an emergency medicine rotation down in Florida.
Nice.
Florida, nice.
Yeah, so we'll see all those Florida men they talk about in the news.
Very cool. Very cool. At least you won't be like burning up in Florida because it's finally getting some cold weather around here. Which I guess this is nothing compared to the Caribbean, huh?
Yeah,
so
chill there.
So that's cool, Florida. Jason, you're off next month, right?
Yeah, but in January I'm doing a compounding rotation.
That's right. Because you really like compounding a lot, right?
It was my interest going into school. It's kind of like what I was setting my sights on initially, and I guess my first rotation, I'm gonna have 2 total. And the first one kind of confirmed the fact that I like it. And then the second time around, I'm going to try and get more into like the clinical aspect of it because I haven't really had much exposure to it despite wanting to do it, which sounds stupid, but that's how I roll.
It's all good.
We're going.
That's how most of us roll.
Yeah.
We just kind of get an idea and go with it and hope it works out.
Yeah. So
half the people in pharmacy school have never even worked in a pharmacy before, so it's fine.
Yeah. So we're going with that. So far, I've liked it. And then hopefully I can get a little bit more into like the clinical aspect of why they do things, because last time it was more of like a technical learning thing to like figure out how to do things and do things efficiently and stuff like that. So
yeah, that's cool. Is it the stuff that you're going to be doing? Is it compounding like non-sterile, where you're making creams and lozenges, things like that, and are you going to be doing some of the stuff in the hood, like making like certain sterile compounding things like hormones and stuff like that?
It was, I guess, considered non-sterile for the most part. Last rotation, I was doing hormone stuff in a hood, mainly for the fact because I think progesterone powder is super fluffy. So if you just like look at it, it'll fly everywhere. So it was more of a mess prevention strategy, I think.
Gotcha.
But most of the stuff I was dealing with when I was at my last rotation was hormones and then flavoring other medications for pets or pain management.
Did you do bacon flavored stuff for dogs?
Yeah, I spilled some like beef flavoring in the hood, and it smelled for like 2 days.
Awesome.
Not good, but there are good flavors out there. With like right when I was leaving, they ordered cheesecake, so they were gonna mess
What?
around with like strawberry cheesecake troches for hormone replacement.
That's cool.
I didn't get to like taste it, but it smelled really good. So
Yeah.
I can only
Cheesecake or the
imagine.
hormones?
The hormones, the
Listen, if I have to eat
Cheesecake
progesterone,
flavor.
it's going to be with cheesecake. I'm going to enjoy this while I do it. No, actually, speaking of like the combating stuff, I listened to a CE from, it was on freece.com. Shout out to them because we had Dr. Kevin Hope on here before. But they had a whole, like, I think it was a 2-hour CE on there about hormone replacement that was all centered around compounding. There's way more that goes into that than I actually thought. Like, I've always just kind of pictured, some estrogen cream, and they have compounds for everything that could be. And same with, compounding certain things like sildenafils mixed with fluoxetine and all kinds of different stuff. Super interesting. So if you have any interest in that whatsoever, absolutely go check that one out. The pharmacist, I don't know her name, so I feel bad, but she did a fantastic job. So great job.
There's a lot of regulation, but there's good money in it too.
Yeah, definitely. There's some cool stuff out there. We need to do one with because they're doing all those things for like the anti-aging stuff now. Should be another podcast that we do talking about the compounding for all that stuff.
They were working on some
Ipamorelin.
stuff. It was for like scar healing. It was to kind of prevent scar tissue from forming. They had different formulations, whether or not it was like new incisions to kind of prevent scarring, and they also had like a different formulation that was slightly tweaked. So for like older scars that people had, that was supposed to help kind of like remove that visual aspect of it, at least to make it less glaring, I guess, because people get self-conscious and stuff about that type of stuff. So
See, my whole face is a scar. So I would just
I was born with it.
all
baited
over.
it.
Yeah. See, scars, like that whole like stupid thing that people say, or scars or tattoos with better stories. Well, yes. Not everyone looks good with a tattoo. No, but no, that's definitely some cool stuff. So if you're interested in that, that was some 2 cents. Definitely check out that those information. There's a lot of cool compounding stuff out there that if you're not familiar with is pretty interesting once you kind of dive into it. Maybe we'll talk about that one of these days. Find out who did that one and have her on the show instead of us talking about it. Probably be a better option.
What we'll do is just air her CE and then release it as our podcast.
Oh man, honestly, that's the perfect idea. There's no way that's going to come back to bite us at all.
Yeah.
Cool. Anything else, y'all? I know we kind of rambled at the end, but anything else? Rashshana, we missed anything else we need to talk about?
No, I think you got it all.
Nailed it.
Everything.
Yeah, perfect.
Perfection. Also, I'll put the link in the show notes, but check out the Medscape article if you really want like some in-depth information on the stuff, because it's a pretty good review. So check that out. But yeah, other than that, thank you guys so much for listening. If you're enjoying the podcast, make sure you leave a comment on iTunes and give us a rating. If you don't want to leave a comment, at least you can click the stars, preferably 5 of them instead of 1. But yeah, if you have any questions for us, reach out to us on any of the social media platforms. You can email us, and our emails will be in the show notes as well. You can text us directly at area code 415-943-6116. And hopefully we'll talk to you guys soon. Thank you much. Have a great one.